of getting the day finished. And after me, there are some awards to announce, so we can get to those as well. I'll get on with the talk that I've been asked to give, which is about the extent of chronic wounds in Canada, what we know and what we don't know. And first of all, oops, I'm not advancing. Not on the screen yet. There we go. Wow. Advancing. Yes, no conflicts. So the objectives I put down there really are just sort of having an understanding of the need for accurate data on wounds, what we do with that, an appreciation of what data we need, and really an understanding of where we're headed as an association in trying to improve the quality of the data that we have. So essentially the reason that we need we need good data really is largely for planning resource management, and that's within the ministry, it's within our healthcare services and within community services. And particularly as the population's getting older with that ageing demographic, the need for planning for health resources for that group is really important. And to be able to do that, we need accurate data with which to do that planning. And as researchers as well, when we're making a case for a research grant for funding, having an accurate representation for the funders of the extent of the problem is very, very important, particularly data that actually show really the scope, when sometimes we're concerned that the data are actually underestimating the scope of the problem. So what are the sort of things we need? Well, we need data on prevalence, and there have been a lot of studies producing prevalence on different types of wounds. Incidence is probably more useful for us, and there aren't as many because incidence is somewhat more difficult to capture just because you need different types of resources. So incidence is really the number of new cases that occur, if we're talking an annual incidence, so the number of new cases of a problem that occur in that year, whereas prevalence is more or less a snapshot in time as to how many you've got in that given time frame that you're assessing, mostly a very short time frame. We need to have it age-related, clearly with this ageing demographic. We need to know what's different in different regions, different wound types, and also what is very useful is to have some outcome data, on what happens to these wounds when we treat them and what happens to our patients. And so having data at these many levels is very useful for all of us, for all of the needs that I've outlined before. Just going back to it, so prevalence and incidence, as I said, we need that for different regions, we need it for different healthcare settings. As far as the health outcomes, we want to know things like healing rates. It would be good to know something about amputation rates, particularly in our diabetic patients. And also the other thing we sometimes forget is the number of deaths that are attributable to chronic wounds. And certainly we see them not infrequently for different types of wounds. Often people presenting with serious sepsis that results in their death. So having an assessment of what that is, and to a degree that means what it is we can help to reduce or avoid. And the other piece is knowing the extent of the problem is also knowing how much it costs. And that's another challenge because the cost data are not always so easy to capture, and we have to have the right tools there to be able to do that. I'm putting this slide up for you because it's just a slide to show you how important it is to look at different regions. And this is from some work in Hamilton Health Sciences. We've been working to develop a clinical vision for our health service for the next 25 years. And part of that is looking at our population of patients that we serve. So this is really looking at different regions in Hamilton. Some of the dots are different regions in Ontario. So what this is, on the x-axis, you've got the percent of the population in socioeconomic classes 3 and 4, so the most disadvantaged socioeconomic classes. And on the left is the number of admissions per 100,000 for the population over the age of 18. And where I draw you to look at is the top right-hand corner of this graph, the red dot. So that red dot is the downtown area of Hamilton, right next to our hospital. And in the bottom left-hand corner, you see, many of the other areas that are the more, shall we say, affluent areas of the city, much less use of healthcare. So this is really a surrogate for the level of patients' health, that they're needing to be admitted to hospital so much. And that equates to the other dots right at the top are more of the outlying areas in Ontario. So they're the more disadvantaged communities. So within eyesight of our hospital, in fact, of my office window, there's a core of people who have such poor access to healthcare. And really, we need to know the prevalence of the problems and the incidence of problems that they have if we're to plan our healthcare. So this is why it's so important to understand, what the extent of disease is in the different sort of areas in our community in Canada. Just try that. We're not moving very well here. So what's the current status? Well, currently there is a lot of data out there. There are data from many different sources, and there have been data collected from different populations, from different regions, from different healthcare settings, both acute, long-term and community. But one of the problems is the different data collection methods, and this is where we come up against issues of the data. And this has been brought forward, to the CAWC from many different directions. But so we see some of this data collected from patient records and databases, which is then limited by the coding ability, by the data capture. Some is gleaned from healthcare professionals, so they give their estimate of what the extent of the problem is. Some come from patient reports. And probably the most accurate comes from direct patient assessment. So when you're actually seeing your patient and you've got some sort of screen you're doing, you can assess exactly what the problem is and whether or not they have the thing you're looking at. And I put this up because the Canadian Institute for Health Information is generally regarded as a good source for health information in Canada. And many of you will be familiar with data that were published a few years ago looking at wounds in Canada. Frequently quoted, and many people I speak to, not really happy with what they see in it. And, my way of looking at data like this is you look at it and you think, well, does this pass the sniff test? I mean, basically, does this smell foul? Is there something wrong with it? And I put up, some examples there, and if it doesn't look right, then the question is, why not? And so here are just 4 simple things I pulled out of their document. So when they report chronic wounds and chronic leg ulcers, they lump arterial and venous wounds together. Well, that's not particularly helpful when we're trying to plan how to deal with those problems, because they're really quite different. They have different resource needs. They report pressure ulcers in the acute care setting as being 0.4%. If it was that good, we'd all be out of a job. And the number of amputations annually, in their document they report in Canada 2,000, and I'll talk about that in a minute. And also no increase in the prevalence of chronic wounds with age, which just simply doesn't actually sound right. So when we look at these and you think, well, first of all, when we're treating venous and arterial wounds, they do need to be separately scoped, and when we're planning for them, they need to be separately scoped because they're very, very different problems that need very different resources. And the reason that these were lumped together is because in some of the jurisdictions they didn't separate them out, so they actually just lumped them all together. Well, that's not a very good way of collecting data for us. And when you're going to the pressure ulcer piece, when you look at data on pressure ulcers, through studies that have been done elsewhere in Canada, studies that have been done elsewhere in the world, when you include stage 1 pressure ulcers, somewhere in the 20s is usually the prevalence that you get. And if you exclude them, you're usually somewhere in the sort of the 8 to 10. So 0.4% just simply doesn't sound right. And amputations, when you look at other sources of data in Canada, the amputation rate on an annual basis would be at least 2 or 3 times what's been quoted in here. So again, doesn't sound right. And most other types of chronic wounds, or most studies that have looked at chronic wounds, find an increase in prevalence with age. So again, this just doesn't pass that sniff test. And the reason for this, this sort of lack of at least face validity in this is that basically it's where the data's come from. So the data's come from hospital morbidity databases, which, you know, as we all know, is so dependent on the ability to code and get things in appropriately. And part of the problem even with that is that the coding system in Quebec was different, so the Quebec data weren't even included in this. And community care reporting system, again, has the same limitations. And indeed, even within this, they cited the fact that there are probably 3 or 4 provinces that don't use the same system, so they haven't even scoped it really across the whole community. And similar issues with home care reporting systems. So not looking at patients, really looking at data, and that's why you end up with these skewed and what we think are actually inaccurate results. Just move on. So what do we need? So first of all, we need agreement in what constitutes accurate data. So what data collection methodology is the ideal methodology to use. And then we need, you know, to recognise that there are differences in different settings, be that different healthcare settings, be that different regions, you know, of the country. And we want to look at an objective evaluation of the current data against what is unideal. So in other words, perhaps look at prospectively collecting some data with what we think is an optimal system and just see how the two compare. And one thing we can do is review the current data and see what, you know, what we think, at least from that, is the best reflection of what is happening out there, but also at the same time to identify the gaps. So this problem was brought forward to the CAWC Research Committee, which formed early last year, and which I was asked to lead, and a number of groups within CAWC, you know, were bringing forward to this committee, we have a real problem understanding the scope of wounds in the country. So what could the committee do? So the committee has considered this, a subcommittee looked at it, and we had even our most recent discussion was earlier today. And so what the committee is planning is to look at this in a really, if you like, a sort of a full evaluation, so in 2 phases. So the first phase is really doing a scoping review of what data are out there in Canada from whatever sources we can find them. And then to identify from those data that we find what we think might be, you know, an estimate of the prevalence and incidence of wounds in the different settings for different wound types. So really, from that, what do we think is the best sort of idea, or what is giving us the best indication of wounds, and then to identify the gaps. So where we simply don't have enough information, we don't have data, you know, where we need to do more. And phase 2 is then to go on and develop as really a research grant application, a project for doing a prospective data collection for assessing the prevalence and incidence of wounds in Canada. And the research committee has been in discussion with the board of the CAWC, and the board you know, has agreed to fund through grant opportunity phase 1 of this project to get this thing moving forward. So, you know, really commend them for you know, having the willingness to support this initiative, because I think it's something that really will be very valuable to all of us. And the plan with that is towards the end of 2017, we will have some data out there that we can share with people that's extracted from existing data sources but has been reviewed in the way that we've sort of outlined. And then at the same time, by that stage, the group will have got together and we hope have a grant application in to do that prospective study that I talked about. So in summary, there is a problem with the data out there. There needs to be you know, a statement or publications that come from a group like CAWC to say there is a problem with the data. We think this is really the best estimate of what's out there, and these are the gaps. So that's what the research committee is planning to do, and have that prepared hopefully towards the end of next year. And then the second phase is then to go on and look at determining in a prospective way, what the real most accurate data that we can get estimate is on the prevalence and incidence of wounds. And this type of data can then be used by our advocacy committee, which can take that when they're advocating to ministry, to health areas for support, for funding, for different types of wounds, different types of problems, different groups of patients. And also will be available to the broader health community and to all of you to use, when you need to advocate for your patients as well. So with that, I'll finish. Thank you very much. So happy to take any questions or comments. I think we don't know whether we have any time left, but we'll steal some time anyway while Mariam's coming up with the awards. Yep. Anyone have any comments, questions, suggestions? Yes?
When traveling amputations, are you just including leg above knee, below knee, or are you including digit, forefoot?
Yeah. No, I think that's a very good question. And when you review, different publications, they do look at all of those, but then they'll break them down into the major amputations. So the ones that I was referring to there, the 2,000, is really the major amputations, below knee, above knee type amputation. And when you look at published studies that break it down, that number of 2,000 is just way below even what other studies are suggesting is out there. Yeah. So yes, you have to define what you're referring to exactly. Yeah. Okay. So we. I'm going to do posters first. Mariam, where are we starting? Posters?
Yes.
You're going to...
I don't have the
I've got it.
information.
All right, okay.
I just have the post. I just have the plaque.
You've got the plaques. Okay, so we've got we're two poster awards. So those of you who took an opportunity to go and have a look at the electronic posters that are down the corridor. We had two judging systems. One was the People's Choice and one was the Judge's Choice. So the People's Choice went to poster number 16, called A First Step for the Development of a Tool to Assess the Probability of Arterial Insufficiency Perfusion in Chronic Wound of the Lower Limb to Support the Nurse's Clinical Decision, Narrative Synthesis Results. And the first author on that was Maurice Beaumier. So if Maurice is here, we have a plaque for you. And if not, if there's any other authors on that paper who are here, you're welcome to come and pick up the plaque for your paper or for your poster.
If she's not, we can show her.
If not, I'll take it home. Okay. Okay. So I think that also won the award for the longest title. And the Judge's Choice was poster number 17. And that was the efficacy of a pressure sensing mattress cover system for reducing interface pressure, study protocol for a randomised controlled trial. And the first author on that was Nancy Claydon. So if Nancy's here or someone from that poster, please come up. Well, I'm going to have two plaques to take home. Okay. No, we'll make sure that those people get the plaques. And so thank you to them and to everybody who really put in abstract submissions for those posters. There were a lot of very high quality posters there, and as a group, the judges who looked at the posters, it could have gone to a number of posters. So congratulations to all of you who submitted posters for that, because the standard's actually really very, very good. So thank you.
And we can't close the day without last two awards. So the social media awards that John will be handing out right now.
Thank you, Miriam. My name's John Gregory, for those that don't already know me. And through this conference, we've been trying to build a presence for Wounds Canada, the hashtag Wounds Canada and CAWC online. We are amazed. We'll run analytics, but we're amazed at how much you have all adopted it. But we have picked out 2 social media winners for today, and that is Gillian Brooke. Okay. And Denny Dallaire. So, if they're not here, we will obviously tweet to tell them that they have won, and they'll have to send us a photo, but we have a couple of things for them. We'll send those out to them. Thank you very much, and keep using hashtag Wounds Canada, please. Thank you.
Thank you. And last but not least, there's a very special person in our audience that we have actually, for the first time in the history of our conferences, a patient in our midst. And Robert has a foot wound, and he has decided to fly all the way from Edmonton to come join us to learn more about how to manage his wounds. And he has gathered all information so that he can take it back to his healthcare workers. So I thought we should be recognizing him today, and we're pleased to give him a gift certificate for a New Balance shoe so that he can take it and get a shoe that can help him with his care. So thank you, Robert, for coming. And thank you, everyone, and we'll see you tomorrow morning. Thank you.